Hello and welcome to this episode of Heart and Health. In this episode, we'll be talking about heart attack or the myocardial infarction. Various types of myocardial infarction have been described in the literature. We'll confine ourselves to the discussion on what is known as type 1 myocardial infarction or the heart attack because of the rupture of the atherosclerotic plaque inside the coronary arteries. What happens is, usually in a predisposed patients, there are some atherosclerotic plaques in the coronary arteries. Coronary arteries are the arteries which supply blood to the muscles of the heart. In these arteries, sometimes because of the atherosclerotic process, there can be deposition of the cholesterol. At times, because of some injury to the endothelium is the layer which covers the vessel wall entirely from the inside. Because of some endothelial injury, there can be thrombosis or the clotting phenomena on top of this atherosclerotic plaque. This is what is known as heart attack, or this is what precipitates heart attack. The other causes of myocardial infarction are relatively rare. When this happens, a significant amount of left ventricle or the muscles of the heart, which are responsible for the pumping functions of the heart, have a significant decrease in the supply of the blood. When approximately 15% of the heart sustains damage because of the heart attack, there is decline in the ejection fraction or the pumping capacity of the heart, which is visible in the echocardiogram. When more than 25% of the contractile mass of the left ventricle is lost, the manifestation is acute LVF or acute left ventricular failure. What happens in acute left ventricular failure is the heart muscles have sustained a significant damage and they are not able to pump out the blood in the forward direction. So what happens is, there are back pressure changes which develop, and where do these back pressure changes reflect? They reflect onto the circulation from which they are receiving the blood inside the heart. That is the lungs. So this increased pressure in the lungs is responsible for the seepage of fluid inside the lung, and this is what precipitates left ventricular failure. The patient is not able to lie down flat or has severe breathlessness. When more than 40% of the left ventricular mass or the contractile mass of the heart is lost, the patient is unable to maintain his blood pressure and systemic perfusion. This state is known as cardiogenic shock and it is highly fatal. Besides contractile abnormality, the heart attack is also responsible for the relaxation abnormality in the heart muscles. When the heart muscles undergo significant damage because of the decreased supply, it changes into a scar. This scar is not able to relax properly during the relaxation phase of the cardiac cycle. Larger the size of the infarct, more is the diastolic abnormality in the patient. Besides systolic and diastolic abnormalities, that is, besides pumping abnormality and the relaxation abnormality of the left ventricle, there is one more phenomena which affects the heart muscles, and that is left ventricular remodeling. Remodeling is the phenomena in which the heart muscles dilate over the period of time after the heart attack. As the left ventricular chamber dimension increases, that is, as the dilatation of the left ventricle increases, the contractile function of the heart decreases. In approximately 1/3 of the patients, there is a trigger which is present behind this heart attack. What are these triggers? These triggers are unusually heavy exercises, and they are usually responsible for a heart attack in a fatigued person or a person who has been habitually inactive. Sometimes the trigger can be emotional stress. This has been well depicted in the Bollywood movies. Besides this, sometimes the trigger can be an acute illness or a non-cardiac surgery. What is known is the peak incidence of the heart attack takes place in the morning, but this is not the rule of the thumb. Sometimes it may not be there, especially in the patients who are already on aspirin or taking beta blocker for some or the other indication. So how to recognize that the chest pain the person is having is because of the heart attack or some other ailment? So first rule, chest pain in a susceptible patient has to be considered cardiac until proven otherwise. This is because heart attack is something which can radically alter the quality and the quantity of life after anyone sustains it. The heart attack mimics are not going to cause much harm to the patients in routine circumstances. So the presence of heart attack in any kind of chest discomfort or upper abdominal discomfort, even throat discomfort, has to be ruled out. At least an ECG should be done in all the patients. Usually the chest pain which occurs in heart attack resembles the angina patient was previously having. The chest pain can occur at rest. The chest pain which previously used to subside with rest may not subside with rest at all. The chest pain may not respond to sublingual nitroglycerin tablets the patient had been taking for anginal pain. Most of the times the pain is very severe and intolerable. The pain may last 30 minutes or so, and at times it can last for a few hours. The nature of the pain is usually similar to the type of pain the patient has during an anginal episode, but it is more severe. Sometimes the picture may be very confusing. At times there may be presence of episodes of nausea and vomiting, and this can very well complicate the picture. This can be confused with a gallstone problem, this can be confused with a gastritis problem, and at times patients confuse and miss the presence of a heart attack. Usually the patients complain that they have got the impending sense of doom, or ghabrahat as they call it, or diaphoresis, that is, they have this incessant perspiration because of this heart attack, and any kind of chest discomfort which is accompanied by these symptoms or breathlessness has to be taken very seriously. Now that pulse oximeters are available in every household because of the COVID, patients are now counting their pulses. What we usually see in a heart attack, that heart rate is on the higher side most of the times. It may not be in every case, but most of the cases the heart rate is on the higher side. In some cases there can be conduction abnormalities leading to a lower heart rate, or there can be an abnormal electrical beat, because of which there can be falsely interpreted lower heart rate in the pulse oximeter. Blood pressure is normal in majority of the patients. In some patients the blood pressure may be on the lower side. In patients who have cardiogenic shock may not be able to maintain systemic blood pressure of 90 mmHg, and these are the sickest patients. And the prognosis in the conditions where the blood pressure is not 90 mmHg is bad. This is a bad type of heart attack. This is a bad type to have. Temperature. So fever is not very uncommon in patients with heart attack. After 4 to 8 hours after heart attack, the patient may have temperature of 101 or 102 Fahrenheit. This is a normal phenomena. It is usually not indicative of underlying infection, and this raised temperature may be present till 4th to 5th day after heart attack, but it may not be present in every case. But in case fever is there, the presence of heart attack is a reasonable explanation for the fever. So how do we diagnose it? So for the basic diagnosis of heart attack, one ECG is sufficient. One ECG is sufficient for taking decisions regarding thrombolysis or primary PCI. What is thrombolysis? Thrombolysis is an urgent medication administration with the aim to take care of the thrombus which is formed in the coronary arteries. And what is primary PCI? Primary PCI is an urgent intervention, urgent life-saving intervention which is done to open the blocked artery. We'll talk about these later in the next episode, but for now, what is to be understood is ECG is sufficient for taking a decision that the patient deserves an angiography, or the patient is to be evaluated for something else. The other most important test is cardiac enzymes or cardiac biomarkers. Cardiac biomarkers are the enzymes which are spilled out into blood after heart muscles sustain damage because of the blocked vessel. There are multiple types of cardiac biomarkers. Commercially, two are available and they are most commonly used. They are cardiac troponin and CKMB. It takes around a couple of hours for these tests to come positive, but we do not wait for the results of these blood tests to start with the treatment of myocardial infarction or heart attack. But yes, these tests these tests provide us very important diagnostic and prognostic information. They confirm the patient has got a heart attack, and they also tell us how much of the heart muscles have sustained damage. The higher the value of troponin, higher is the amount of heart muscles damaged by the heart attack. Bedside echo may be available in a cardiac facility, and this might help to solve some confusing cases when we are really confused what it is the patient is having. And one more thing that patients are really fascinated about is CT angiography. CT angiography may be useful in patients with stable chest pain or patients where we are confused about the etiology of undiagnosed chest pain, but in setting of myocardial infarction or heart attack, the value of CT angiography is very limited. The value of CT angiography is very limited. Patients have to be evaluated by conventional angiogram. We have to know the exact severity of the disease. We have to exactly localize the presence of the blockage, and there we have to correct it. So conventional angiogram is of paramount importance. In the coming episodes, we'll be talking about the role of antiplatelets. Aspirin you must have heard, and the other antiplatelets which are available. We'll be talking about the thrombolytic therapy. Thrombolytic therapy is the therapy in which we administer a drug hoping that the clot which is formed inside the coronary artery will dissolve. We'll talk about percutaneous interventions which are done for the patients of heart attack. And these are the topics we'll cover in the next episode. Till then, bye.